Hi, everybody. Thanks for joining us. We'll just wait a few minutes for people to arrive and connections to be made properly. We'll get started in a few minutes. Hi, everybody. Thanks for joining us. We'll just wait. Well, it's almost 3 minutes past 6, so I think I will make a start. Thank you very much for giving it your time this evening. I hope it's going to be what you expect and what you hope from this webinar. So my name's Priya and I'm one of the co-executive directors of the Equality Trust. The trust was set up in 2009 by two authors of The Spirit Level and another epidemiologist. So it was set up by Kate Pickett, Richard Wilkinson and Bill Kerry in 2009 following the publication of The Spirit Level. And that research found that inequalities harm everybody in society. So this evening we've brought you here together to kind of think about health inequalities, and with the NHS in the UK being free at the point of delivery, it might seem logical that we all have equal access to and experience of healthcare, but this is far from the truth. So in the London borough that I live in Haringey, there is a 16-year gap of healthy life expectancy between the richest and the poorest parts of that borough. So for men, it's 71 years in Highgate and 55 years in the north of Tottenham. And that's from a 2019 report. So, while it might be tempting to blame individuals for their lifestyle choices, and there's not really enough time here this evening to go into the cycle of inequality and poverty and the impact that this has on those choices. Tonight, we want to consider the systemic issues at play and how many of these are both intersectional and cumulative. So, for example, poor housing, which contributes to poorer air quality, both indoor and outdoor air pollution, and it also contributes to the lack of green space and, of course, other space. And I think Fran's going to explore a little bit more about the systemic and drivers of poor health outcomes more in her talk. But we also can't ignore the biases within healthcare. We're all too aware of the horrific and sometimes fatal experiences of Black and brown women in maternity care and the long and awful history of the overdiagnosis and over-medication of Black people within the mental health care settings. And sadly, these biases are not restricted to humans. A report published this week reveals biases within medical tools and devices, for example, those used to measure oxygen levels, and states that these have almost certainly led to Black and brown people experiencing poorer health and mental health care settings. And our second guest tonight, Dan, will be sharing his report on AI in healthcare, exploring the vast potential for AI to do good and to maybe circumnavigate some of these biases, but the current reality being that, well, I'll let Dan go on to speak to that. And finally, this evening, we will look at democratising and co-producing health priorities with the people who stand to benefit the most from interventions. One of the three key principles of the Structural Inequalities Alliance, of whom the Equality Trust is a member, and we therefore integrate these principles in our work, is the principle of participation. The premise being that to change society's structures, we must first change who designs it, and that those most affected by policy should be partners, including in the planning, decision-making, and in accountability. So this evening, we're welcoming Hannah and Sally here to tell us about their co-produced priority setting project, which we hope will spark some thoughts in all of us as to how we might incorporate this principle more or incorporate this principle differently in our work going forward. So I will let each of the speakers introduce themselves. So thank you very much for your time, for being here, for all of our speakers and all of our guests joining us to listen. So we'll start with Fran.
Priya, and I'm just getting my screen ready to share whilst talking. Lovely to be here this evening, and really looking forward to hearing from the others on the panel. So just to say a brief bit about me, so I'm Fran Darlington-Pollock. I am Chief Executive at Greater Manchester Mayor's Charity, who are an independent charity who believes homelessness has no place in the city region. But before that, I had a brief stint at Save the Children, but much longer stint as an academic, so population and health geographer. And during that time, I wrote a book, which came out in 2022, which I'm going to talk a bit more on today. And I'm also former chair of the Equality Trust. So that's me. So inequality matters. It really, really matters for our health. And because of that, it really matters for our healthcare. Now, 85 years ago, or just over that, in fact, Sir William Beveridge presented Parliament or a committee of Parliament with this report, this very well-read report from me, which was a radical blueprint for what rapidly became one of the most admired manifestations of the welfare state around the world. And in that report, he targets 5 giants that he saw as standing between a flourishing society and, for that time, the road to reconstruction in the aftermath of war. So those 5 giants were want, disease, ignorance, squalor, and idleness. And I wrote one of 5 books with 5 other sets of authors to kind of commemorate the Beveridge report 85 years after it had been written. Now, Beveridge called for a complete overhaul and not just piecemeal reform of the social security system. And he wanted it to be built on the principle of meaningful cooperation between the state and the individual, a system that protected against, and I'm quoting him now, the interruption and destruction of earning power and for special expenditure arising at birth, marriage, or death. The idea was that the population would be able to have access to a whole range of benefits, including things related to unemployment, disability, training, and maternity. So this was at all points of the life course, including support through retirement with a pension provision. And most importantly, he established a national health service where care was provided free at the point of delivery. And it was the first universal medical system in the world. I really, really like talking about the NHS or the birth of the NHS when I'm sat right here, because 1.5 miles that way is Trafford General Hospital, which was the very first NHS hospital opened by Andrew and Bevan himself. So the NHS, this was a landmark institution championed in that blueprint, and it's been the focus of enduring but occasionally waning admiration of our British welfare state. And there are a few things that are important to consider in the context of this discussion of inequalities in healthcare and the origins of the NHS. So first, when Beveridge submitted that report in November 1942, life expectancy at birth for women was around 66, and for men it was around 60. For every 1,000 births, there were 52.9 deaths in the first 12 months of life. So that's the infant mortality rate. At the same time, fertility rates, so the number of babies being born, was really, really low. And Beveridge was amongst many who were pretty concerned about the risk of population decline, something they were even more alarmed of because of the recent collapse of the British Empire. They wanted children to be born, and despite the fact that the war years had seen the kind of raising of the status of women in the labour market, that really rescinded in the aftermath of war, and the expectations for the women of the country at that time didn't really extend beyond the kitchen or the nursery. However, when Beveridge was writing this report, and he wasn't aware of this at that time, the numbers of babies being born was actually going up, and we were soon to see the advent of what's now known as the baby boomer generation. And this signalled a really significant change in the size and structure of the population. All of this matters for the health of the population because it matters for the social structure, it matters for the age and gender composition, the economy, and the politics of that society. Now, Beveridge wrote that a revolutionary moment in the world's history is a time for revolution and not for patching. You can definitely see that was from what was going back on in back in 1942, and now and 2 years ago when that book was published that I'm talking on today, it's not any less true. Before I go on to the next slide, I'm going to give you another quote. And this quote was fundamental to the argument I'd put forward in the book. I should say, though, the book wasn't particularly novel, nor was anything I said in it. But there is a kind of a need for continued discussion of this, particularly as actually only yesterday we had a report out from the World Health Organization saying pretty much the same thing in terms of gender inequalities, health outcomes, health systems, and empowerment of women. So that quote, it's a quote from a Norwegian sociologist specialising in peace and conflict studies, and he called Johan Galtung, and he said, if a person died from tuberculosis in the 18th century, it would be hard to conceive of this as violence, since it might have been quite unavoidable. But if he dies from it today, despite all of the medical resources in the world, then violence is present. So what is avoidable? What's avoidable death? What's avoidable illness? What's avoidable hardship or poverty or inequality? At the moment, these days, there's quite a lot of avoidable all of these things. So let's focus in on health. It's pretty important to pretty much everything we do, and therefore it's pretty important to everything we can do as a society. And if I asked all of you right now to rate your health, you're going to consciously or subconsciously consider a few different things. Do you live with a chronic disease? Do you have an acute infection at the moment? Are you currently injured? But you probably also, whether you're aware of it or not, factored in conditions like where are you living and what's your sense of security? And also the breadth of other things that might either enable, maintain, or disable your general well-being. So health is very much more than the absence of disease. And this is an important conceptual discussion as it gives us space to look really critically at the healthcare system that Beveridge proposed relative to what we might propose, and I suspect what's going to be talked about later, given how we evaluate our health and how broad an evaluation of health we would actually make. This is probably really different from the sorts of evaluations within more traditional biomedical conceptions of health that framed the time that Beveridge was writing. They would have been more likely to prioritize diagnosing and treating the biologically deviant state of disease, and that would be probably at the expense of less tangible ailments and definitely at the expense of the wider context that shape health for individuals and for populations. But if we're talking about inequality in the experience of healthcare, we really do need to have a very social conception of health, and we need to capture everything that makes us whole, sound, or well. So I'm a quantitative academic. I can't help but give you a few graphs, but there's not many, and they're nice and simple. So we'll go here. And forgive me, I've not actually updated these since the book, but it's pretty much the same. And also aware that on screen, this graph is really hard to read. So the men are the dark line at the bottom on the graph, and it's women on the top. And this is showing life expectancy for birth, at birth, for men and women from 1842 right up to around 2020. That glitch that you're seeing at the end here, as I'm sure you can all understand, is the impact of COVID. But the overall message you should be taking from these graphs, or from this graph, is that there was significant improvements to life expectancy for the population that came into force not only because of the NHS, but also the wider provisions of the welfare state as they took effect. So we had improvements in living conditions, better lifestyles, and the medical advances that were coming in the post-war period as an engine for accelerating what then became a century-long period of sustained annual improvements to life expectancy. And as we can also see, the gains in life expectancy were mirrored in falls in infant mortality rates, so deaths to babies under the age of 5, this one is. The problem is that when we reached the tail end of that sustained improvement to life expectancy around this 2014, and at the same time we saw infant mortality rates begin to increase. And if our babies are dying more often in the first 12 months of life, even if these increases are only small, this is definitely the canary in the coal mine falling off its perch and a really clear signal of something significantly wrong in our society. More importantly, it's avoidable. In 1996, Merrill Singer, he was an anthropologist in the States, and he spent some time looking at the health outcomes of people living in an inner city area of Connecticut. And this area and this city was one of the poorest of cities in the United States, and it also had very high levels of crime. But, and this probably isn't a surprise to anyone, the poverty and those poor outcomes across different societal outcomes were not evenly felt across the city. And it was the Puerto Rican migrants there who suffered the most. Now, Singer argued that the reason this group suffered so much more than their African-American or white neighbours was because of the combined burden of the social, economic, environmental, and political context of their lives. This group not only endured mutually reinforcing and co-occurring health problems such as substance abuse, violence, and AIDS, but they were these kind of co-occurring health conditions were amplified for the Puerto Ricans because of the context in which they lived, a perpetuating configuration of noxious social conditions. Noxious social conditions are lethal because of the social determinants of health and the uneven distributions of income, wealth, and power. Singer used the experiences of the Puerto Ricans in the States to coin the term syndemic, a phenomenon that was aptly applied to the experiences of COVID for marginalised and minoritised ethnic groups in the UK by, amongst others, Professor Claire Bamburgh. Syndemics help us make sense of uneven distributions of poor health when they're exacerbated by the context of people's lives. If we are to allow, which we should, for a social model of health, we're recognising the social determinants of health. So it's the cumulative influence of things like the socioeconomic profile of where we're born, the schools we went to, the sorts of houses we live in, the amount we earn, how polluted the air we breathe is. All of these and other things are important for our health. They shape our health, how long we'll live in good health and when we'll die. This is where the violence starts to creep in. If we're talking about differences in the context of where people live or the schools they can access, jobs, houses, etc., yes, we're talking about social determinants, but we're also talking about political determinants. We're talking about policy choices of investment or not, or even of disinvestment. We're talking about avoidable hardship. We're talking about structural violence. So syndemics are the lethal consequences of structural violence, which can only be understood through contemporary biosocial and not biomedical models of health. And syndemics are going to be ever more common where polarized societies, corrupt power, and unequal chances are depressingly common. Syndemics and structural violence seem to explain a lot. Looking back then, the fiscal response to the global financial crash of 2008 was, if you can remember, you probably can, was relatively modest tax increases and major public spending cuts, all with the intention to reduce the deficit and stimulate economic growth. The deficit did fall a bit, but economic growth didn't materialise and the economy stagnated, and we now have this sustained cost of living emergency. So the widespread cuts that we saw to public spending led to significant reductions in social security, unpicking and eroding a security net woven by Beveridge that had already begun to gape open. COVID hit socially and economically disadvantaged communities the hardest, not because they didn't follow the rules, but because of the noxious social conditions they lived in already increased vulnerability to a range of chronic health conditions. They had underlying health conditions was a phrase too commonly applied when reporting the latest daily death toll during COVID, and it's never an acceptable excuse, but particularly when the chances of having an underlying health condition are so unevenly and unjustly distributed, linked to wider policy choices and uneven power distributions. Now, I think the importance of place and politics to inequalities in health is really clear in these next two figures. First, infant mortality rates by deprivation, and you can see that generally the higher the level of area deprivation, as we go up here, so 1 to 10, the higher the rates of mortality. Or we can look at adolescent mortality rates in Scotland, and we know that the highest rates are in South Ayrshire. I have no idea how you say that, so sorry if that's wrong. And that's one of the most deprived regions of Scotland and an area where nearly a quarter of children are living in poverty. So we can look at these sorts of interactions between deprivation, place and health with use of healthcare just as we can in terms of health outcomes. For example, this graph is actually looking at vaccine uptake during COVID-19 by area deprivation. And the highest rates of vaccine uptake are this dotted line along the top, which are in the least deprived areas. And you can see that for all age groups, basically, the more deprived the area, the lower the vaccine uptake. This is structural violence. This is avoidable ill health. This is avoidable death caused by policy decisions explaining the structures that create this. So Beveridge was the catalyst to the development of a revolutionary healthcare system, but one that was focused on treatment rather than the prevention of ill health. Though once transformative to the health of the population, the system that's emerged hasn't kept pace with the wider transformation of society. Beveridge did not design a system for an aged or aging population or one that is ethnically diverse. He didn't design a system for a society that is persistently unequal, and he didn't design a system that's been able to withstand the doctrine of neoliberal marketization that gives primacy to the market over the individual. The NHS is the classic political hot potato, a money pit that no politician really wants to touch, but no politician can reasonably ignore. Since its creation, we've had successive efforts to lower the bill and seen more and more emphasis on narratives which are derived from neoliberal individualism, placing responsibility for health and poor health on the individual and the individual alone. Weigh in too heavy? Lose weight or pay for your services. Ignore the fact that your access to healthy, nutritious, affordable food varies according to your income. Ignore the fact that your time you have to cook, the space you have to store provisions also varies according to your income. Require more care in older life because of the toxic social structures you live in have not only made you iller earlier, but also meant you earned less and therefore have less of a pension to support you in later life. That's a struggle. Struggling to get access to a medical professional for a non-urgent but potentially developing serious health or well-being problem. Fine if you can go private. If not, good luck. We haven't built a resilient healthcare system, and we haven't invested one either. And we've not even got close to developing a resilient, sustainable social care system. Reforming health and social care isn't a simple task, but we definitely do need to do more than patchy reform, because the existing model isn't sustainable. It doesn't have the resources or capacity to address the increasingly complex health and wellbeing needs of a larger, older, and more diverse population. Perhaps more urgently, we have also become complicit in the struggles of the NHS. We're expecting what ails us to be really easily medically cured. We want antibiotics for a cold or a cough. So we've welcomed a social model of health, but ignored the social determinants of good health. We're victims of our own success because the medical advances that bolstered and pushed those gains to life expectancy we saw previously have created the space where we too often believe that a cure can only ever be from a prescribed pill. So the silver bullet of medical intervention has led to a medicalisation of society, where we seek pharmaceutical intervention too quickly. And this is largely driven by market forces and big pharma capitalising on the desire for that magic silver bullet. So the medicalisation of life and society is not only compromising the ability of the health and social care system to meet demands, but it's also creating a dependency on healthcare, which is overlooking what could be resolved within our social support networks and a better funded social care system. So Beveridge's vision has definitely carried us as far as it can, and the revolution it prompted is no longer sustainable in the face of demographic change, or capable of addressing the structural inequalities of income, wealth and power that can be so lethal for so many. Last moment here. Galton talked about the tendencies of societies to perpetuate patterns of inequality because of the nature of their hierarchical structure, and what that then means for the social, economic and political interactions within them. This will, he said, continue unless deliberately and persistently prevented from doing so. So is it now time for deliberate and persistent intervention? Inequality and structural violence can be and are so often ignored by any whose wealth, income or self-esteem appears to buffer against it. But to have that bit more than your neighbour in a society of inequality is just that. It's not to flourish either as an individual or as a society. This has been a whirlwind tour of my brain and that book, but just to conclude, Beveridge created the NHS in his assumption B. So I'll conclude with what I think our assumption B.2 should be. This is one that recognises the violent structures of society, recognises that we're actually all complicit in this violence unless we're persistently and deliberately doing something about it. One that recognises that health is socially and politically determined, and that the perpetuation of toxic, noxious social conditions because of structural violence will always worsen, with lethal consequences, the health outcomes of marginalised and minoritised groups in society. One that recognises that any health and social care system has to recognise all of this if it's to do any effective preventative and curative work. So our assumption B.2 is premised on a care economy where care is community-led, valued and reciprocal. It's premised on a society committed to dismantling structural inequalities of income, wealth and power. And it's premised on acceptance that inequality is definitely not inevitable.
Fran, thank you so much. Recognise a lot of equality trust wording there. Really fantastic to see that it's not stopped with your chairship. So sorry to everybody, I forgot to mention that we will have time for questions afterwards. You can either pop them in the chat or just note them down, and we can come to that when all three speakers have finished, and you can turn your camera on and share your question then. So thank you so much, Fran. Really a lot to think about there, a lot of historical stuff and a lot of what we can do going forward. So great to hear from you. Thanks so much for giving your time today. We're going to move on to our second speaker now, who is Dan. He is, I will let him introduce himself. Dan, off you pop.
Perfect. Thank you very much, Priya. And thank you very much, Fran, as well. I thought that was super interesting. Right, there we go. Hello, everyone. So, and thank you as well to everyone at TET and yourself, Priya, for the invite tonight. So I'm Dan Guest. I'm currently working as a policy and strategy project manager in NHS England, where I focus on vaccinations and immunisations. I'm actually on the NHS graduate scheme, which I started in 2022. And I previously sat in clinical policy, mostly working on sort of long COVID cases. I always have to pronounce the long properly because of my Black Country accent. I realise that a lot of people think I'm talking about my lungs. In November last year, I was privileged enough to spend just over 2 months working with the Equality Trust on a research piece into artificial intelligence and health inequalities, which is what I'm going to be talking through today. It should be noted that this is not an exhaustive apparatus to examine the field, but I'm hoping it's to get some minds thinking and some brains flowing. So the context behind this piece was for it to be a baseline situational analysis into the relationship between the use of artificial intelligence within healthcare and health inequalities. So in this sense, it's not about finding solutions, but it's to generate further points of discussion. Following the COVID-19 pandemic response, NHS England devised the Core 20+5 approach to tackling health inequalities. So in this, the Core 20 are the 20% most deprived population, and that's as it's identified in the Index of Multiple Deprivation. The plus populations are identified at a local level by local providers, and they broadly cover those that share the protected characteristics within the Equality Act and those that are covered by Inclusion Health. The 5 represents the 5 key clinical areas which the NHS England Health Inequality team have said that needs to be addressed most urgently. So that's maternity, severe mental illness, chronic respiratory disease, early cancer diagnosis, and hypertension case finding. And governance for all of this sits within a centralised team within NHS England. The origins of this report build from the announcement of the AI Diagnostic Fund in June 2023. So the AI Diagnostic Fund is a package of around £21 million to enable the accelerated rollout of AI technologies across 64 NHS trusts in England. The National Institute for Health and Care Research, that's the NIHR, will develop in tandem new in-service evaluations for the tools that are being deployed. As there continues to be significant investment in this field, it's really important to understand the impacts that this has on equality much more widely. Because of the nature of the report, we thought it was best to focus specifically on one aspect of the healthcare ecosystem. And for that, we decided on cardiovascular disease. There's many reasons as why we decided to focus on CVD. Firstly, cardiovascular diseases remain to be the biggest cause of death globally, and 1 in 4 deaths in England are attributed to cardiovascular diseases. It also has a higher than average diagnostic error. Long-term health conditions can be monitored by addressing topics such as CVD, as well as viewing the challenges through a more intersectional lens. One of the most important reasons that we looked at CVD is due to the level of socioeconomic disparities within cardiovascular disease. And this covers nearly all aspects, including initial research. So, for example, women are still chronically underrepresented in cardiovascular research, and that's through implicit sex-biased inclusion criteria, such as age limits, body size limits, and other cardiovascular indicators. These sex biases go on to shape gender biases, such as persistent inconsistencies in risk detection. And as a result, women are less likely to be prescribed medication and are at the higher risk of being misdiagnosed. As a further point, people living in the most deprived areas of England are 4 times more likely to die prematurely from cardiovascular disease than those in the least deprived. It's also the biggest factor in life expectancy gaps within the United Kingdom. And another key reason why we're looking at cardiovascular disease is because AI is being used widely within this disease area. I've listed a few examples on the screen here, such as diagnostic imaging and creating individual treatment plans. And from the discussions that I've had with various people within the NHS and outside, it seems that the current direction of travel is much more towards the risk prevention and prediction, and that's to try and enable proactive policy-making decisions. But what does this mean for inequalities? Whilst there is some movement towards utilising AI to reduce health inequalities, these are currently quite jagged and uneven. For example, there's a big increase in using telemedicine in underserved communities. And while this can help bridge geographical-based inequality gaps, it doesn't tackle the core socioeconomic disparities within this area. And so an example of this is using wearable technologies, and that can help predict disease trajectory going into the future. Another key area that it's being used in is to develop personalised risk models for individual patients. But examples of this, particularly within risk prevention, is often outside of the field of healthcare, and within the field of healthcare, it has quite mixed results. There was a big study in the United States that found a healthcare risk prevention algorithm demonstrated racial bias because it relied on faulty metrics for determining need. And this was used in over 200 million patients in the USA. So this algorithm was to try and help hospitals and insurance companies to identify which patients would benefit from high-risk care management programs. So this was to try and get them to have more access to specially trained nursing staff and to allocate extra primary care visits for closer monitoring. But the research found that while Black patients tended to receive lower risk scores, when they actually looked at the cohort, Black patients were 26.3% higher chance of having chronic illnesses. So although they had a lower risk score, this wasn't reflected in the actual cohort. And I think one of this means is that we have to have robust evaluation mechanisms in place. So that leads us to asking the questions, where do we go from here? AI holds promise within the healthcare ecosystem, and evaluating the effectiveness of AI necessitates proportional evidence standards and effective regulatory oversight. An intersectional AI system is needed, and by this, we have to ask, what are the right tasks for AI? Can AI really take on the core tasks within healthcare, such as clinical risk prediction and diagnostics? We also need to reduce bias within the data interpretation. Most of the data in CVD seems to be based on bias sampling. So where is the right evidence standard for AI? And this must ensure a clear demonstration of clinical effectiveness. And finally, I've written that healthcare inequalities must precede AI. And what I mean here is that ultimately, health inequalities as a topic and as a scheme of work cannot be replaced by AI. We need to examine integration approaches that support rather than replace healthcare professionals and healthcare inequality streams of work in the field. Moving forward, it is crucial to anticipate and strategically address emerging trends from the world of AI, in particular with relation to cardiovascular disease. This includes ensuring that developments focus on societal need rather than commercial opportunities, and that AI governance is independently regulated. So I hope this whistle-stop tour has highlighted the intricate challenges and opportunities that are inherent in the integration of AI and machine learning technology. Whilst there is potential for AI to change the cardiovascular healthcare landscape, careful consideration must be paid to the risks that may exacerbate health inequalities. Resultingly, organisations and researchers must ask important questions to strenuously challenge AI developers in the field. This will test the reliability, usability, and adaptability of AI technology across social landscapes. So let's leave it there for now, but I hope it's been interesting, and hopefully there's been some brains thinking about where we can shape AI into the future, as it's certainly not going away. Thank you very much.
Thanks so much, Dan. That's really interesting. And it was great to have you on board, working alongside us, developing that report. And it was really interesting, all of our kind of check-ins and conversations as we developed direction of it. And it's really great to see it come to fruition. So thank you for coming this evening and sharing that with us. I know you've moved on to a new job, so that's fantastic. Our next two presenters this evening, we've got Sally and Hannah. And they, I think I've mentioned earlier, they worked on a co-produced project looking at healthcare priorities, and they're going to share some details of that project with us this evening. So welcome, Sally and Hannah.
Thank you very much. I'll just introduce myself first. I'm Sally. I'm from a social enterprise based in East Manchester in an area called Gorton, for anyone that doesn't know Manchester. And we're a social enterprise that focuses on health and wellbeing, and I manage a community centre in Gorton.
Hi, and I'm Hannah, and I am a public involvement and engagement specialist. I am an associate at an organisation called Vocal, and we connect people with research. I think we've got some slides.
I think they're about to appear. Thank you.
Thank you very much. Okay, so our project was called Gorton Health Matters, and this was a community priority setting project in East Manchester. So today we're going to quickly talk about who we are and the organisations that we are representing. We're going to talk about our work, why we carried it out, and how we did it. We're also going to talk about the results, and then have a little bit of a reflective period to think about what we learnt. In the image here, you can see members of our steering group who were a working group and advised and showed us what to do in the project, running a community mapping exercise. It was one of the first things that we did in the project. I'm sorry that it's so dark in my room. I've got an energy saving light bulb on and it doesn't seem to have worked at all today. Okay, next slide, please. Thanks. Okay, so first up, I am an associate at an organisation called Vocal. Vocal has a vision of bringing people and health research together for everyone's benefit. They create opportunities for people to have a say and find out about research in Greater Manchester. They're specifically an organisation that works in involvement and engagement rather than participation, and what that means is they work in a way that you might be more familiar of as co-production than kind of your traditional engagement.
And Healthy Me Health Community is the organisation that I'm representing. So we're a social enterprise, as I mentioned before. So we've been going for just over 10 years. So we're all about co-producing health and wellbeing services that empower, educate and inspire for a happier, healthier and longer life. And what that means on the ground is we run different communities. We work very closely with partner organisations, and we run different projects like food projects, such as community grocers, which are social supermarkets, crisis food projects, exercise classes, courses to help people get into employment, volunteering opportunities, and lots of different things. But our main thing is that we work with different organisations to co-produce together.
And then finally, we also were partnering with the James Lind Alliance Lab. So the James Lind Alliance Lab is part of the JLA, which is a non-profit making initiative that brings patients, carers and clinicians together in priority setting partnerships. The JLA priority setting partnerships, or PSPs, identify and prioritise unanswered questions or evidence uncertainties that they agree are the most important, so that health research funders are aware of the issues that matter most to the people who need to use the research in their everyday lives. So the JLA Lab is an experimental space for priority setting activities that don't sit within that kind of very traditional methodological way in which priority setting partnerships are usually carried out. And that's where our project sat at the James Lind Alliance, because one of the things that we really wanted to do was push the boundaries on power sharing and democratization within that methodology and have a more participatory model. So in terms of our work, this was a place-based piece of democratisation. We worked in partnership with Gorton residents, community organisations and primary care services to develop local health and wellbeing priorities. These weren't research questions. We specifically wanted to move away from it just being purely about research. So these are priorities that can be used by the community as well as by health research to move away from an extractive model. We hoped to learn what health and wellbeing topics residents felt were important so that we could improve the way we work for residents in Manchester. So our aim was to generate a list of top 10 questions or areas that could firstly be shared with researchers in Manchester and beyond to develop research questions, but secondly be used by project partners and others to develop projects, set strategy, and also apply for funding for our smaller grassroots organisations that would struggle to get evidence-based stuff in their funding normally. So what is priority setting? So priority setting is a partnership with the community that enables clinicians, patients and carers to work together to identify and prioritise evidence uncertainties. We've kind of gone over this, but what I really wanted to be clear is that with a priority setting, you start from that foundational point and you set strategy and you make decisions based on what the community have told you. Traditionally, that's in a research area. We specifically wanted to broaden that out so that we weren't just talking about one area of research. We were talking about community needs and wider health inequalities when we were having those conversations. And so also what public involvement is public involvement in research means research that is done with or by the public, not to, for, or about them. You may have heard of this as nothing about us without us. It's a really foundational part of democratising our services. It means, and it's been around since the 80s, it means that patients or other people with relevant experience contribute to how research is designed, conducted and disseminated. It does not refer to research participants taking part in a study. And just to be really clear here, anything in terms of the NIHR, the National Institute of Health Research, has to have public involvement within a research project, but not necessarily outside of that research project and within kind of strategic spaces and decision-making spaces. So why did we carry out this project? Sally and I have actually been working in partnership together for a couple of years now. We've done a number of different projects together, including Represent, which was a transnational piece of research about barriers to participation in early cancer detection research. As part of that work, we talked with our local community. I'm also a Gorton resident myself, by the way, about what was preventing people from taking part or being engaged in research. And one of the big things was that they felt that coming to a community with a predefined idea, a predefined research question was frustrating. And actually there needed to be space that sat outside of the traditional research question cycle for more involvement and not just engagement. So there was a request for a pre-research phase of public involvement. And also that community experience often didn't fit the boundaries of what researchers were researching. That residents often shared really, really important stuff in these sessions, but it didn't fit into the project's objectives, which led to frustration really for everybody involved, because you don't want to come to a space and people share some really heavy stuff and there's nothing that you can do within your research project. So that's kind of where this started from. We also drew from the work of Dr. Bridget Pratt, who talks a lot about power sharing in priority setting models. And the thing that she that really sticks with us is that presence needs to have voice if you're going to have involvement, and voice must have influence. So that influence must actually improve health. That influence, people must be able to actually make change within co-production, within participation and involvement. And so we know from evidence that people in rooms with influence and voice improve health research and improve health outcomes. And so for us, the question, the experimental part of our work was how might we expand the scope of the conversation and also enhance the depth of our participatory approaches in the priority setting process. I'll pass over to Sally. Oh, no, sorry, I won't. I forgot about this slide. One of the things that we had we had 5 key points that we wanted to talk about in terms of the foundations of our project. One of those was power sharing with each other and sharing power in the room. We've chosen this picture to show that traditionally with the James Lind Alliance workshop, the final workshop is run by members of the JLA. And the thing that we wanted to do was make sure that we all came together as a community, as our steering group, and led that workshop collectively. So you can see here that we were all working together and we all facilitated different rooms together, the community leaders, the residents, and also JLA members as well. We worked with grassroots organisations and groups. So traditionally in health research, it's very difficult to work with organisations that are community groups, don't necessarily have the physical infrastructure to work with large organisations. We've partnered with Healthy Me, Healthy Communities intentionally because they incubate smaller grassroots groups, and in that way we could reach deeper into the community and to a much more diverse group of organisations doing really exciting, really interesting things that us in the health research world might not normally get to meet. We also wanted to make sure that this was a period of exchange, and so the community were giving us so much advice on how to do really good community engagement, and the JLA also provided training for upskilling in terms of facilitation of participatory models for the community. Also, one that is really important and just has to be said, everyone is paid. Everybody that took part in this piece of work was paid. They were either paid an hourly rate or they were remunerated with gifts when we were talking about the people that were taking part in the surveys, just because we couldn't work out how to get 200 people through our systems. We also talked about sharing impact, outputs and impact. And what was really specific here is that sometimes involvement in projects can be extractive when it comes to outputs, because we kind of set the idea of the project and then the output is kind of what the organisation or body wants. So we really, really wanted to make sure that our output was useful to our community organisations in terms of funding and prioritising. So one of the things that we kind of did slightly different to a traditional PSP is that some of our top 10 are not unanswered research questions, and they are in fact just really significant community priorities that need further funding. But that's part of sharing power and sharing outputs and impact.
Okay, so I'm now going to speak about what did we do, so how we carried the project out. So we the first step was we built a steering group, and in the first steering group meeting, we all worked together to identify partner organisations to work with and engagement locations to carry out our outreach. The second part of the project was we did the outreach in 2 phases. So we did our first phase of outreach, and we carried this out in 18 locations. So this was all, as I mentioned, decided by the steering group in terms of where we were carrying out the outreach. And just some examples of where we carried it out was a local mosque, 2 food projects that run here at the centre, and a local exercise group called AfroFit. And the next part was the theming of the issues. So we had community representatives, and they carried out the theming workshop to sort the questions into themes. And the next part was we carried out the second phase of outreach, which was community voting. This was carried out in 4 locations, and this included Gorton Market, which is a local big market which everyone in the community goes to. So it was a really good way to engage with different people. And also a project called Gorton Visual Arts, which works with adults with learning disabilities. And then the final part was our final workshop. And this is where we identified the top 10 priorities. And this was through a consensus building workshop. So this is the top 10 that the community decided on at the final workshop. And just to mention as well, in the photo is a picture of Fozia. So she's a local resident that was part of the steering group. And one of the things that me and Hannah arranged was for the 3 facilitators at the final workshop to be community representatives. There was Fozia, who's a local resident, and 2 other people called Takala and Idawu, who are leaders of grassroots groups. And that was because we really wanted the final workshop to be led by people that represented the community. So we're just going to talk a little bit about what we learned. So we found that community members provided really important feedback in the theming workshop. So Hannah, do you want to explain a little bit more about that?
So one of the things that we found really useful was, and very important, was to have members of the public carrying out the thematic analysis with us. Traditionally, that's not somewhere where you'd have involvement from the public within these models, but it really, really allowed for quite in-depth conversations about what was meant or shared when people were talking about the different things that were happening in Gorton. And it really helped to reduce that kind of assumption or bias that you might have when discussing priorities, because a lot of these statements are it's quite limited information. And so having somebody be able to contextualize or debate that and discuss that together was really, really valuable in helping us to appropriately theme and group and kind of write up these priorities.
I'm sorry, can we just go back to the, thank you very much, sorry, just to mention as well is we also found in the project it opened up routes for support for those that might not have otherwise engaged. So we took on this centre a few years ago as an organisation, Help Me Help Communities, and we're still very much trying to do lots of outreach and engage people in the community. And through this project, we engage with lots of people who might not have done otherwise. A couple of examples of that is that one of our outreaches at Gorton Market, I had a conversation with someone who was looking into volunteering, but they didn't know where to start or where to go to. So I invited them to come along and have a conversation with us about doing it here. And they've since trained up to be a volunteer and are regularly volunteering with us each week. And that's hopefully in the long run going to lead them into employment. We also had someone come to one of the workshops who'd been struggling with quite a few things for quite a while and again wasn't quite sure where to go. They came along to a workshop and then a few days later came in to have quite a long conversation with us, where we were able to refer them to quite specific support. And they said that they felt, because they'd sort of built the trust and felt listened to in the workshop, that they're able to then come in and have a conversation with us about something quite sensitive. And just to link on from that as well, as we have learned some new sort of outreach techniques which we haven't carried out before, and also locations that we haven't thought of doing outreach before. So we're going to use those going forward for further outreach for our projects.
And finally, we just wanted to say thank you to all of our absolutely amazing partners. Loads and loads of different organisations enabled us to come together and do this work. We got a free market stall, got a market for a week. Southway Housing gave us free community rooms when we couldn't find anywhere else. The library hosted us. Angels of Hope and Women Arise taught us how to do 1-minute planks, which we were surprised to have to do. And Gorton Visual Arts, it was really lovely to share their final project with them and share community in that way as well. So thank you to everybody that has made the project possible. It was a real community effort. And please do get in touch.
Oh, thank you so much both for sharing that. And if we've got a bit of time extra at the end of the session, you can be teaching us your 1-minute plank tips and techniques. So thank you very much to everybody for sharing your time and your research with us today. If people have got questions, please do put your hands up or put your cameras on or put some questions into the chat. I'm going to start the questions off. I've got a couple of questions for Fran. I thought what I would do, Fran, is give you both the questions that I've got now, and you can think about them and work out which one you'd like to answer first. And meanwhile, anybody, again, please do feel free to jump in. It's great to hear from other people and get people to ask questions while we've got our speakers here. They're not always here together. So Fran, in your presentation, you mentioned a revolution, the needing to kickstart things. So I just wondered if you could give us any sense of how close we might be to this revolution, in your opinion, and maybe, you know, what communities and people can do to kind of facilitate or shape the revolution, or what grows back after the revolution. And you also, one of your graphs, I think it was on the life expectancy graph, you know, you mentioned there was a dip off there, and you said, of course, that's, you know, the impact of COVID. So I just wanted to ask about, you know, what impacts and when we might expect to see the impacts of cost of inequality, cost of austerity, cost of living crisis. You know, what might we see coming up on graphs in the future, and when might we begin to see those impacts coming through?
Okay, I'll start with the second one. It's just because it's there. That in terms of the cost of the impacts coming through, we could look back. So if austerity started around 2010, and when did we start to see the first stall in life expectancy? And that started to happen in 2014. And then for women, we actually started to see a reverse a few years later. So women were dying younger than their kind of like previous generations. So that's 4 years showing the kind of real severe effects. And austerity particularly hit women the hardest. You know, it was women who are working in part-time jobs in public sector. They're more likely to be on those contracts, which means not only they're the first ones to be kind of like, oh, we could lose that, but they also will be hit financially hardest by pay freezes, which were very common across the public sector. So there was this kind of double whammy on top of everything else that was already going on there. So you will already be seeing it, is the first simple answer. And for example, in the context of homelessness and rough sleeping, we have seen huge increases in the numbers of people rough sleeping in the latest announcement that came out at the end of February. And this is driven by the twinned crises of housing, of the failing welfare provision and problems around things like local housing allowance, and also through very, very avoidable hardship caused by changes to asylum policy. So things play out in real time, but then also you see that accumulated lag. So we're already seeing it, and it's probably going to get worse, is the kind of not very happy answer to the second question. The first question, how close are we to revolution? I think quite close in some ways, particularly if, as should be, communities do facilitate this and do argue for it. The whole point for me of my argument in the book is structural violence, and is that we are all complicit in it unless we do something about it, because we keep just watching it happen. Even with all of the great work that's happening from people in this room, this virtual room, it's still not enough to have kind of seen real change. And I think the problem is that we just keep voting in the same sorts of people, whatever party they're a member of, who are doing the same sorts of things. There's no co-production, co-design of policy. Look at the kind of disaster behind universal credit, for example. So every time we just allow that to happen and don't kind of turn around and say, why is that happening? What is going on here? We're allowing it to just stay. There was that whole view of build back better. I thought that was a terrible, terrible phrase, because build back better suggests just a stronger version of what we already were. And we were already a complete mess. So we needed to kind of build back completely different. There hasn't been the pivot that some would have wanted in the aftermath of COVID, but actually maybe we just need much more of the fundamental change. And I should caveat all of that with, I spoke in quite positive terms about Beveridge, but let's just temper that with, actually, he was misogynistic, he was racist, he was perpetuating a whole kind of set of structures that were problematic then and are even more problematic now. So the revolution that he saw, and not just on his own back, there were plenty of the people, including women, who led to that, But we do actually need some kind of revolutionary approach now. And people like Hilary Cottam, the work that she's done on this much more relational approach, and kind of where you are putting people and communities at the centre of it rather than kind of institutions, is probably the way forward.
Thank you, Fran. And I'd noticed I got very excited when I saw the Sue Gray thing in the newspaper that she was, wanting to bring in kind of citizens' juries, and then promptly 12 hours later, that was whipped away again. So thank you. Of course, if people have got questions for Fran, please either raise your hand, you can put your questions in the chat box, and we can come to you. I can read them out for you, or you can put your hand up and turn your camera on and ask those questions yourself. Maybe I'll put some questions to you now, Dan. In your presentation, you talked about, the issues with, bias data that's being given to these AI and, machine learning. So have you got kind of ideas of, how to prevent this happening again? Where is the non-biased data already out there that we could be using? And it felt in your presentation today that we concentrated a lot on, the really negative parts of AI, as they, the potential harms. Are there any examples of them working for good currently, or where would you see that happening going forward? Or is it, literally only a kind of horror story awaiting us? And building up on that, sometimes when I hear technology, it just screams profit extraction and furthering inequality. So, have you got any kind of ideas of, whether that's true, or whether it's just, my own bias coming into play there? And, what can we do to kind of mitigate against that risk, I suppose?
Yeah, thank you very much. I think most people, when they think of new technology, especially within healthcare, always think about the commercial interests. And I think there is definitely an element of that in the AI Diagnostic Fund. But I'm hoping one of the themes that I think came through all three presentations was this idea of co-production. And there is an excellent opportunity right now to have co-productive policy making taking place. That's not to say it is occurring right now, but I think there is the potential for it to occur. And one of the biggest elements of that is, while they've put £21 million into it, NIHR are developing the evaluation tools in tandem with the rollout. And so I agree that there was a sort of focus there on the negative, but that presents an incredible opportunity for those that, if we can get into that space, to develop an AI plan, an evaluation plan that focuses on everybody in society and can be co-produced with everybody in society, to really try and reduce some of those biases that are currently in the data. In terms of whether there are examples of unbiased data, I think that the sort of answer to that is pretty much no. But I think you have to look at a holistic approach of how we can mitigate data sets as a whole. How do you reduce bias in data sets more generally in society? And I know that's the discussions that we had quite a lot in our catch-ups, is this about taking a step back from AI, taking a step back from health inequalities, and viewing everything much more holistically from a societal level? And do we have to tackle inequalities at a much higher level first before we can really tackle health inequalities when we're looking specifically at AI? I hope that sort of answers some of the questions that you've put up there. And there is incredible opportunities within AI as well, within healthcare and without, to put forward. So I don't want it to be all doom and gloom, but you always have to evaluate, do those positives outweigh the potential negatives that can come through? And I think there were some excellent comments in the chat as well about the fear that it can exacerbate health inequalities, which it could definitely go down that path.
Okay, thank you very much, Dan. And to Hannah and Sally, I think, what you presented tonight certainly sparked a lot of interest in me, and potential of how we can be thinking more about incorporating co-produced kind of priority setting in the work that we do. So, if people have got that kind of spark, enlightened, is that the right word? Ignited in them, what might some of the next steps be? And I just also wondered, just a very, very specific, honed in question about the project that you ran. Was the voting the only way that you talked to people about setting the priorities from that long list of the themes that you had to reach that top 10? And have you seen any impacts as yet to the work that you've done in that priority setting?
So I'll start, and I will first say, no, it wasn't the only way that we engaged with people in that second phase of engagement. In fact, all of the voting was done in spaces after conversations anyway. But we wanted to make sure that we worked with that diverse range of people. So we basically prepared booklets, and we went out and we sat down. We had teas and coffees at Gorton Visual Arts, and sat down with members of them and talked through what was happening. We also worked with adults with learning disabilities to make sure that everyone's voice was included. And so in that sense, we still engaged through the Gorton Visual Arts artistic process, but also having those conversations at the same time. It was always the same model in terms of the ending of the engagement was the vote. But that's because of the process. But the ways in which we approach the voting change depending on the communities that we were engaging with.
Thank you.
And in terms of the effects it's having already, so we will be sharing our findings with all of the local partners that we work with. And I've already been looking at we apply for funding regularly, obviously, with the type of organisation we are, and I've already been looking at, information and findings that we can use to kind of help us with funding applications. And it's also been helping us to inform us of kind of what sort of work we need to be doing to be filling gaps in what there isn't in terms of support for people in the community, for example. And I know some of the grassroots organisations that have been involved have also been already using some of the findings and discussions already in their own work.
Yeah, and we will be disseminating all of this work through the Clinical Research Network. I know that they want to take the findings to develop some training for their engagement teams and also for their researchers so that they can think about how they're better engaging with communities, but also just so they can understand Gorton a bit more when they come with their appropriate research projects for the area. And then I should also just say that we did finish this project 14 days ago. So not much has happened since, apart from kind of breathing and calming down from a bit of a high. It's hot off the press. Yeah, this is very, very immediate
Put
news.
a finger on the pulse. Oh, well, thank
and
you
then,
very much. Yeah, Karen.
Oh, your final question in terms of what can people do if they're interested in priority setting. So this was a really big piece of priority setting in terms of the funding that we needed to gather for it. But there's lots of different ways of doing priority setting, and there's lots of different ways of democratizing your services. There's some incredible bits and pieces online. And the James Lind Alliance are always interested in talking to people. I'm also very happy to have conversations with anybody should they want to do it. But, priority setting is just one thing. There are citizens' juries, there's deliberative democracy, there's amazing myriad of ways of engaging people in your decision-making processes.
Thank you very much. Thanks, Hannah and Sally. Aideen, you have your hand up.
I do. Hi, I do.
Hi.
Thank you. It hasn't been mentioned. I wanted to mention ageism as another source of health inequalities, where we've highlighted, I'm from the Centre for Aging Better, so we've highlighted it in a number of things. We have our big campaign going on, which I hope you've all seen, and we have the Harms of Ageism paper on the website. So both through self-ageism, the way people limit themselves, and overt, actual ageist practices and lack of practices. So I just want to put that into the mix as another source of health inequalities in later life.
Can I just add in? So in the book, in the report from Beveridge, he has the problem of age as a section in it, and he's just kind of arguing around, people get older and how do we resource this? And then in the book, what I talk about a lot about that internal ageism and how things like, so baby boomers, I referred to baby boomers in the talk, and then you see cards kind of ridiculing boomers or kind of ridiculing old age, particularly women. We kind of make a joke out of old age, and this is just a really passive version of something that's really insidious in how we kind of get to a point where you're 65 and over, and suddenly that's it, you are grouped as a single homogenous group who is dependent on a population. Even the way we talk about them in demography is the dependency ratio. So we've kind of set it up to be a real problem right through the life course, and then if you go back to the kind of cumulative impact and the fact that people who are in more socioeconomically disadvantaged situations are going to have higher costs in the life course that they haven't been able to recoup because of the kind of the impact on them, then an aging population is a really significant issue that no government has fully recognised, even though it was completely kind of forecastable based on what the population is doing. But again, it's a really, really important one to look at with an aging society.
Yeah, well, we could talk about it for ages. I mean, one of the things we've got, because we're evaluating the campaign, we've got this baseline data, so we've been looking at it, and we see that people in lower socioeconomic, people who are struggling, are much more likely to have experienced ageism than those who are a much larger proportion of those who are very well off say no, they've never experienced it. So you see a real intersectionality there also, which is just sort of exacerbating, everything just gets magnified and exacerbated. Thank you.
Thank you, Aideen. And I haven't seen your research actually, so maybe if you could pass that over to me, at some point, that would be fantastic to see it.
Absolutely will, yes. Please, and please distribute it.
I will. So has anybody got any more questions or any questions for our guests? I mean, I've got a pie in the sky wishful dream one while we're all here and we've got these experts around the room, but I don't want to hog the floor. So if anybody's got questions, please do save my doorbell and the dog going crazy. But maybe I just thought, in the interim, we could think about, we have got a general election coming up. Do any of our panelists have any ideas of, what we could be asking of, the next incoming government in order to kind of address some of these health inequalities we've seen and even reverse them, maybe? Should we start with you, Fran?
I think to a large extent, we do need to completely reform health and social care that is fit for the population that we have now and that we are kind of expecting to have. So that is for all ages and for all backgrounds, cultures, ethnicities. We should also really, really call for more active investment in the health and social care workforce, because that's a kind of huge area where I don't just seem to ignore it. And actually, whenever we've got acute health workforce shortages, they have historically just recruited overseas, but then the policy environment at the moment doesn't really allow for that either. So there's kind of really strange short-term views which kind of attach to election cycles as opposed to attach to actually the lifespan of a healthy population. So if we could shift policy to think long term rather than in a 4-5 year cycle, and really call for all manifestos to be looking at that and committing to it, which is difficult because obviously as soon as the budget changes they just do something different anyway, but I think that we should be holding them to account for that more routinely than we do, because we also get caught up in those election cycles and what did they say last time and they didn't do that, or they've moved to this, rather than being like, actually hold this, allow for the budget to change, recognise that it's going to, and give us something that is actually sustainable.
Thank you, Fran. Dan, did you want to add anything on?
I mean, there's not too much to add from my side. I think I completely agree with Fran, and being in NHS England, I can't speak too widely, but we do see that it's based on 5-year cycles. and particularly up to an election. With this general election coming up, I know there's lots of talks about which projects can go ahead, which projects can't, particularly when we have that standstill period where we can't publish any new policy. And it does have a big effect on the way that NHS England operates. And I think a longer term view, as Fran was saying, if all parties could agree to something like that, would be excellent.
Yeah, thank you. Hannah and Sally, any
Um,
final words?
I didn't hear the question fully because there's a bit of a problem with the sound on my laptop.
Sorry, I
but
was also turning my mute on as soon as possible because my doorbell
that's okay. I
doing
think
nutty
I got the
things.
general gist. All I would
Yeah,
say,
so just, you know, we've got a general election coming up, and, you know, obviously health inequalities are you know, a huge issue. Have you got any kind of thoughts of what we could be campaigning or asking of our incoming governments to help kind of address or even reverse the situation of health inequalities as they stand?
it's hard to think off the top of my head, but what I would say is certainly working in the area we work in this type of work we are in the centre, this area is particularly high level of deprivation, and you can really feel the kind of complex needs even over the last few years that people are just struggling with lots of different things, and the needs are very complex, and often it feels like the third sector is filling in those gaps because there's been so many cuts, there's been so many things going on. So the need is increasing, but the support is decreasing. And ourselves and lots of other organisations we work with, we're very stretched, and we can just really feel it because we're in the sector that are filling in the gaps.
That's an unsustainable model. Thank you. And Hannah, did you have anything you wanted to add?
Yeah, it's the thing I've been saying, and I think the thing that lots of us have been saying for years, decades. We need to move away from the deficit model. Fran, you touched on it earlier, but stop thinking about people as individuals that need blaming, and start thinking about relational, empathetic, long-term services where people can feel safe and trusted to talk about the complexity of their needs. One of the things that came up the most often within our piece of work was conversations about GP surgeries. And a huge number of people talked about a GP who had worked for 30 years in a practice and had recently retired, and the impact of losing that relationship with their GP had on their health and their well-being was enormous. And it was numerous numbers of people that gave us that feedback. And so, yeah, I think long-term relationships with services that care is really, really important. And that can only happen with more funding.
Yep, thank you very much. Well, in the absence of questions from our audience, we seem to have done really well for time. So I'd like to thank all of our speakers for giving up their time to us this evening and sharing their incredible research and experience and, you know, knowledge and research from their books and stuff like that. We're going to put some in the chat. We've got Dan's report on AI and healthcare that you can have a look at, download from our website. And we would really, really appreciate if you can, please fill in a feedback form. It really helps us at the Equality Trust with, you know, planning for our future webinars to kind of think about what topics people are finding interesting and, you know, concerns that they have coming up that we might be able to kind of find speakers to think about and discuss with all of you guys. So thank you very much for your time. I really enjoyed everybody and learned a lot from spending time here and listening to everybody and seeing their work. So thank you very much and good evening.
Thanks, bye.
Thank you very much.
Bye.